Okay, let me just make sure. Did it move? Okay. Okay, so today, obviously, we're talking about postpartum psychosis. By the end of the presentation, my goal is for you guys to have a better understanding of what postpartum psychosis is and to understand the needs and experiences of women and their families who have had experience with this, and to translate this into interventions that can be put into practice. So, a little bit about postpartum psychosis. It is part of the perinatal mood and anxiety disorders spectrum. It's on the farthest end of the spectrum as like the rarest and most severe, affecting, approximately between 1 and 2 per thousand women. And just for comparison, the baby blues affects up to 80% of new moms. And for postpartum depression, that number's between 10 to 15%. It's considered a psychiatric emergency in part because if left untreated, there's a significant risk of harm to the mom or baby, including suicide and infanticide. So in most cases, it does require hospitalization for the mom. Most women present with severe mood symptoms, so mania, mixed episodes, or depression with psychotic features. Symptoms typically start within 3 to 10 days after giving birth, although occasionally symptoms may start more than a few weeks after birth. And the symptoms can vary a lot and change really rapidly. So, in addition to the affective symptoms, there's a delirium-like waxing and waning of consciousness, disorganization or confusion, insomnia, irritability, and then abnormal thought content, so delusions or hallucinations. The delusions often feature a maternal or infant-related theme. So some examples of that are usually more persecutory delusions. So believing that someone might be out to harm you or your infant, believing you have to harm yourself or your baby to save them from some perceived threat. And then women also experience prodromal symptoms. Oopsies. Including irritability, mood changes, confusion and disorientation, and insomnia. The most significant risk factor is having a personal history of bipolar disorder, followed by a personal history of a previous episode of postpartum psychosis. Women who experience a first episode have a 50% risk of developing bipolar disorder. And then for another almost 50% of women, no risk factors have been identified. So sort of a crapshoot. Um, it has been demonstrated to have a genetic basis, and the significant hormonal and immune changes that occur after delivery are thought to trigger the illness. Epidemiological studies suggest that the onset is within the first 12 weeks. However, prospective clinical studies found most patients have acute onset within the first 2 weeks. And despite the severity, prognosis is really good with quick treatment. Um, and then of women who go on to have more children, more than half are at risk to experience another perinatal mood episode. So not necessarily postpartum psychosis, but something within that um, postpartum mood and anxiety disorder spectrum. The Massachusetts General Hospital Postpartum Psychosis Project was established to collect data from women with histories of postpartum psychosis across a large international cohort. Um, as of November 3rd, 2022, 248 participants with histories of at least one episode completed the interview. Most participants met criteria for bipolar 1 disorder with psychotic features. And during the episode, the psychotic episode, the vast majority of women experienced odd beliefs or delusions. Almost half of the participants reported that their symptoms waxed and waned, as opposed to presenting more consistently over time. And most participants reported that their psychotic symptoms lasted between 1 day and 1 month, while about 24% of episodes lasted between 1 month and 6 months. 10.5% lasted greater than 6 months, and just under 2% lasted less than a day. The median time between delivery and symptom onset was 10 days, and participants reported a median of 25 weeks or around 6 months as the duration of time to return to a self-reported psychiatric baseline. Excuse me. Among those who experienced a recurrent episode, the median duration of time to psychiatric baseline was 10 weeks or around 2.5 months. So barriers here. One significant barrier is it's still not included in the DSM as its own distinct illness. While technically it can be accounted for by using the with peripartum onset specifier, a panel of experts who published a recent statement in, I think, Biological Psychiatry, had recommended it be included as its own category within the bipolar disorders chapter. They highlighted, among other things, that it doesn't fit into the currently available categories, and the peripartum onset specifier inaccurately describes the timing of onset. Because I believe it can be, with peripartum onset, can include up to like 4 weeks during pregnancy, and this is specific to after pregnancy or after delivery. In part because it's not included in the DSM, providers are less familiar with it. There's no single or unified screening tool, and screening can be really difficult because of the range of presentations and the fluctuating nature of symptoms over time. Also, because the onset is typically between 3 and 10 days after giving birth, the woman is likely already discharged from the hospital. And so the identification often falls on the family or support system. So if we as providers are not that well versed in it, families also aren't. This also happens in the context of being newly at home with an infant and all of the stress associated with that, the stress and the sleeplessness. And so earlier signs are often missed or normalized by healthcare providers. And then I think for me, it seemed at least one of the biggest barriers is the stigma surrounding maternal mental health. There's this myth of the perfect mother, or the societal expectation that pregnancy and motherhood should be universally joyous, which can be really invalidating to people who experience something other than that. It also can lead to a woman's distress being dismissed as temporary or the result of hormonal changes. The perfect mother myth also becomes so internalized that if you experience something other than what's portrayed on social media or wherever, there's maybe a message of there must be something wrong with you, you must be doing something wrong, maybe you don't have the maternal instinct. There's also the fear of judgment and consequences. So moms understandably fear being labeled as unfit and worry about how their mental health could be used against them, especially in some sort of court proceeding, custody hearing. And then more specifically to psychosis, women can appear asymptomatic and know what to say in response to internalized stigma. And I imagine we've all had experiences with clients who minimize their symptoms because they have that internal stigma of they know how it's going to be received if they admit to hearing voices or seeing things. So Ford and colleagues conducted a qualitative study to explore the psychological needs, experiences, and preferences for psychological intervention for women from the perspective of women and their family members. Three core themes emerged that highlight that recovery is a complex and active process in which women's needs change over time. It also illustrates the range of psychological needs that have to be met to facilitate change and promote well-being. So the first theme, seeking safety and containment, this is during the acute phase, and here participants felt that practical support, emotional containment, and safety should be prioritized. They did not want formal psychological intervention at this stage, and this is, at least initially, usually involves like hospitalization, ideally in a mother and baby unit. So participants reported extreme distress, overwhelm, fear, and confusion. Having a label and an explanation helped relieve some distress. However, conversely, delays in receiving a diagnosis exacerbated their sense of fear and uncertainty and risked damaging the relationship with health professionals. So here the interventions are sort of direct, completing a prompt assessment and providing information about prognosis once a diagnosis is made. It can also be helpful to provide family and the woman support to boost their understanding of postpartum psychosis. And a lot of the participants found it really helpful to be signposted to credible information as opposed to just sort of being let loose to read message boards where there could be some scarier content that they come upon from other, like just women's experiences. Can be helpful, at least initially, to give them some direction in terms of where to look. So the second phase was recognizing and responding to the psychological impact. Recovery was a slow process influenced by the wider context, including interactions with family, peers, and professionals. This process was not linear and sometimes featured relapse or the onset of depression or anxiety. An illness representation helped to externalize the experience, reducing self-blame and guilt by allowing women to view postpartum psychosis as a disorder related to childbirth, which was out of their control. Women also described a need to relate to other women with mental health difficulties, which can be done by connecting with peer networks, which also help to normalize their experiences. It was during this stage, after the acute illness, that women sought psychological support to help cope with the emotional impact and placed a lot of value on providers who recognized and validated their experiences. This is also a time to encourage family to consider their own emotional needs and help link to the appropriate resources. Women needed to process and make sense of their experience before they could successfully transition and accept their altered sense of identity as both a mother and someone with lived experience of postpartum psychosis. When this need wasn't met, women described feeling invalidated and unable to move on. So this can be a really long process, but it's critical to provide them the time and space to process the trauma associated with the psychotic episode, process the sense of grief associated with the loss of what was expected, and to process memories or gaps in memories. So here, recognizing the long-term impact and promoting techniques to enhance coping skills, self-care, self-compassion, and self-acceptance. By utilizing strategies, for example, creating a timeline by themselves or with family members, writing down their experiences, reviewing medical notes if they sort of have gaps in their memory and want, an outside objective opinion, women were able to develop a narrative of events that helped enhance their understanding and ability to cope. And women and families acknowledged the importance of their relationships that helped facilitate recovery and really benefited from support in managing the changing nature of these relationships over time. So this can be achieved by providing opportunities for joint input to talk through any concerns, and provide guidance to family on how best to support, when to withdraw, how to sort of balance that, because it changes throughout the course of their recovery. Initially, a lot more support is needed, but gradually that, you want to step down from that so that a woman develops like a more of a sense of confidence in her skills as she starts getting better. And then the last theme was planning for the future. The sudden nature of the illness caused women to question their ability to detect fluctuations in their well-being. Women worried about future episodes and highlighted the need for ongoing professional support akin to relapse prevention. So creating a relapse plan can help women feel more confident in their ability to recognize symptoms and have a plan for how to manage them. This also helps enhance their understanding and promote well-being. And a common theme from women was a desire to turn their experiences into something good for others. As many women noted, knowing someone else got through this helped them remain hopeful that they could also get through it. So by connecting with other women, this enhanced their recovery by enabling them to talk through and further process their experience, connect with other women with similar experiences, and help them feel like they regained a sense of control over their lives. And this is also an opportunity for women to reflect on their internal resources that helped get them through. This is very much in keeping with the concept of post-traumatic growth, where positive psychological change can result from a person's struggle with challenging life experiences. So by reflecting on their inner strengths and adjusting to their new identity, women demonstrated more compassion and acceptance towards themselves. And this recognition of renewed strength and resilience enabled a more optimistic outlook and enhanced their self-belief regarding their ability to cope. Here are some resources. The first one is the expert consensus statement that includes the proposed criteria for this being included in within the bipolar disorders chapter. And the next one is a really interesting article that I would recommend if you have time reading. And then there's a few other resources, including 2 support groups that could be helpful should anyone have experience with a client who has had this experience, and then my references. Does anyone have questions?